Hi, my name is Dr. Wes, and today we're going to discuss Addison disease and neuronal linkage. Addison disease, that is due to the damage or shrunken adrenal cortex. The core idea: adrenal cortex failure causes low cortisol and usually low aldosterone, which may result fatigue, weight loss, hypotension, salt craving, hyperpigmentation, hyponatremia, and hyperkalemia. The emergency condition of the patient may require urgent IV steroids and fluids. History: the disease is named after Thomas Addison, who described adrenal gland failure with wasting and skin darkening in 19th century. Typical hormonal pattern: low cortisol, often low aldosterone, and high ACTH because negative feedback mechanism is lost, which results in decreased cortisol, decreased aldosterone, decreased sodium, increased potassium, and low blood pressure. Adrenal cortex, the cortical zones. These are the cortical zones: zona glomerulosa, zona fasciculata, zona reticularis, and which in which the layers can be affected. So both glucocorticoid and mineralocorticoid replacement may be required. Neuronal linkage, HPA axis, hypothalamus pituitary axis, that is called that is the neuroendocrine pathway, stress input, hypothalamus pituitary, and negative feedback mechanism, which is lost in this disease and results in hyperpigmentation, low blood pressure. These are the few aspects of this disease. Cortisol stays low, and so due to the loss of negative feedback mechanism, ACTH may raises. Neuronal linkage in Addison disease mechanism. There is an The mechanism: adrenal block, CNS consequences, hypoglycemia, hyponatremia, hypotension can cause confusion, weakness, irritability, depression, seizures, or coma in crisis. That is the adrenal damage to the symptoms. Adrenal cortex might be damaged due to infection, hemorrhage, infiltrative disease, or autoimmune. Autoimmune is the major cause of disease in our society. Decreased cortisol levels, it causes aldosterone decreases, salt loss, water loss, potassium retention. Increased ACTH losses, loss of cortisol, negative feedback mechanism. Clinical disease: fatigue, hypotension, hyperpigmentation, and crisis. System effect: low cortisol, low aldosterone. Neuronal and pigment effects: high ACTH rises because pituitary keeps trying to stimulate the failing adrenal cortex. Brain system in crisis are often secondary to hypoglycemia, hyponatremia, and poor perfusion. Clinical presentation: chronic fatigue, generalized weakness, loss of appetite, salt craving, hyperpigmentation, low mood. That is the second is the laboratory clues: hyponatremia, hyperkalemia, hypoglycemia, and eosinophilia may be present in some cases if the infection is the cause of the disease. Adrenal crisis clues: severe weakness, collapse, vomiting, diarrhea, confusion, seizures, severe abdominal or back pain. Diagnosis: that is the very important part. Clinical suspicion include fatigue loss, weight loss, hypotension, hyperpigmentation, salt craving. Initial labs: morning cortisol, ACTH, sodium, potassium, glucose. Confirmatory test: ACTH, osinotropin. Classify primary ACTH high, secondary, tertiary ACTH low or inappropriately normal. Find cause: 21 hydroxylase antibodies, CT MRI when infection, hemorrhage, or tumor is suspected. That is the interpretation. Treatment and management: glucocorticoid replacement therapy, mineralocorticoid replacement therapy, lifestyle and safety, and monitoring of blood pressure, postural symptoms, weight, electrolytes, renin where available, and sign of over or under replacement. That is the image showing the Addison crisis. Emergency mechanism: triggers infection, surgery, trauma, vomiting, diarrhea, missed steroids, or severe psychological stress. Danger: low cortisol and aldosterone causes hypotension, dehydration, hypoglycemia, hyponatremia, and hyperkalemia. Steroid therapy should be there for the patient without any delay. That is the prognosis. With lifestyle and steroid therapy, uh, many patients can live active lives. Poor adherence causes the disease to get worsen. Patient need clear instruction for fever, vomiting, surgery, and trauma. Safety education should be there for the patient, so he or she regularize uh, intake of the steroids on daily basis. That is the summary. Brain stress centers: hypothalamus, CRH release, pituitary ACTH release, adrenal cortex fail, cortisol decreases, aldosterone decreases, and clinical symptoms of the disease may appear. That is the neuronal linkage, and that is the hormonal consequences. High ACTH and POMC may causes hyperpigmentation. Thanks and regards. Please like and subscribe this channel. Thanks.